I have been like doing these procedures, like endovascular procedures, for decades already, I can say. And I have been doing like direct carotid puncture and brachial puncture as well. And there's no need for those anymore. Like for the carotid puncture, you need the patient to be intubated, and then it's much easier to do from radial. And then when we have all the new devices in conjunction to the radial access, so that you can use ultrasound, the very special good probes for radial approach, and then all the sheets and everything, it's much more designed nowadays than it used to be like for 10 years ago. So there's so much development in the devices that you couldn't just imagine. For me, and I think for the most people, it's mostly less complications, less puncture site complications, because most of us nowadays, like the elective patients, we preload the patients with dual antiplatelets. And I think some of us say that they never have the puncture site complication, but I doubt that. Everybody has puncture site complications. So it shortens the time of recovery if you have a complication from the radial puncture. And then we have the economical issues, because it shortens the patient's stay at the hospital and the recovery time as well. And then I think we should also take into attention what patients prefer. I think like 99 out of 100 patients want to do radial if we ask them. As far as I know, so it is, in Europe, yes. And I need to say that these were like all the first radial procedure that we did, and we only used twist in these procedures. So it includes like the learning curve for us as well. And I need to say that the learning curve was quite fast for us at the end, when we noticed that it didn't take like more than 20-30 patients, so that we felt very comfortable with the procedures itself. But like altogether, so the conversion rate from radial to femoral was only 4%, and I think that's quite a low percentage. As well, the complication rate, we had 4 puncture site complications, yes, but despite of that, all the patients were discharged the following day from the hospital, and that's totally different compared to if you have the puncture site complication from femoral approach, because nobody of us wants to have the retroperitoneal bleeding for the patient. So I think those were the key findings. And then like the thing that you can learn fast if you just want to have the results and you want to learn something. It's like driving your old car and you are like satisfied with that, and then you think that it's pitfalls, but then you are just like, you're comfortable with those. So that's the same if you are doing femoral and you have some things that they are not working too well, but you're just ignoring those. So I think those people who are using their old car should switch to the new car, that's the radial, and then they would sort of like, they would find out that there's different ways to get out of the problems they have, like because we are treating more and more elderly people for ischemic stroke especially, so radial is the first one. And then we have those physicians who say that they don't want to learn something new, and I think they feel uncomfortable with the new learning, with learning new things, and they should just like forget that and let other people teach and show how to do that. We shouldn't be too proud to learn new things. The current limitations, I think, because not like the older generation is not that used to do the ultrasound when they are doing the puncture, so they need to learn that first, and then the equipment what you have, so you need a good ultrasound machine, so everybody does not have that, and then you have the radial extension and everything to do yourself and the puncture and the procedure more comfortable, but that needs a little bit more material into your practice. And then you can't do everything from radial at the moment, no, because the device development is not at the very high level yet, so it takes time. I strongly believe there will be a lot of studies in the future comparing radial and transfemoral access, comparing the amount of X-ray, the amount of timing, like how long time you do your procedure from radial or from femoral, and then what has been quite a lot talk about in the last papers is like the hits you might get when you are doing radial. Are those important, and is it real, and does it matter at the end? But I think we still need both ways to do the procedures. We are not going to forget femoral at the end, because from the radial I would love to do like thrombectomies, but the devices are not suitable for thrombectomy if you want to have the large bore aspiration catheter. At least like in Europe we don't have those available yet. So it takes time for that. But I strongly believe that radial is the future for the most of us.